This will be about data conversions in general, and my disclaimer here, as I love to do, is obviously anything that we're sharing today is not legally binding, mostly comprised of our experience plus tips and tricks found online, etc., to create this presentation. I'm aware that there are probably 6 or 7 or 8 different types of conversions, and everyone's got a little bit different situation, whether it be you're a large organization that brings on practices in the healthcare environment every other day, it seems like, or if you're a smaller organization that is simply being purchased or is being gobbled up into another group or merging, things like that. I'll try to sort of make and give examples relevant to all. And then at the end, we will open it up for any questions or any specifics that you guys might have that you'd like to see answered. All right, so essentially, just a little bit of an intro here. So obviously, why do I need a data conversion for anybody thinking about it? In the reform days, if you're required to capture so many percentage of race, ethnicity, language, religion, and gender, and all that stuff, obviously that those data points are needed, and having them in a data conversion, if you don't have all that and you just dump in 100,000 patients without that data, your numbers are going to look pretty bad when you're running the report. So sometimes that can be a pretty big reason. Obviously, the more data, the better. So you could argue quality of care, improved performance, and that type of thing. So obviously, the more information you have at the time the patient presents, the better. So that's always good to have. And why would you need to convert again? So some of the hassles is maybe if you take on a new system or you change systems, or you're finding that you bought a system and the sales guy sold it to you and it's not exactly as promised. Maybe you need to bring in some of the data from your old system to help bolster that, because that solution didn't necessarily meet your need. That's pretty much a big complaint you get from the specialists out there, but that's one of the reasons, or maybe you're leaving because your vendor just wasn't giving you the love that you needed. So you're going to convert away from them and convert onto a new system. Something like that is always in the cards. And of course, with any data conversion, little background here, there are certain things that you have to do every time, and we'll talk more about it, but there's always medical, legal situations to be considered. Maintaining the patient's legal record for X number of years is certainly part of the game here. And then, of course, other considerations like when it comes to system sales, usually data conversions are the last thing anyone's thinking about it. I mean, even the broad term data conversion is so general that you think it can be done at any point, but really it can take months at a time for something like this to happen and happen correctly. And it's sort of often an afterthought. Takes a lot of planning and expertise. Obviously, something you really need to have. A lot of people try to do that in-house, and that's okay, but usually you want, when you're doing a data conversion into the systems that are out there today, especially the ones that are in these latest and greatest healthcare reform versions, they need to be done by folks that know what they're doing to hit all the right spots, not somebody just combing through the database and sort of guessing at it. So there's a lot of considerations that fall into that category that really need to be taken seriously. And then why do conversions fail? This list will grow every time you do one, and so needless to say, knowing these ahead of time can absolutely be vital. Planning, yeah, of course, we'll talk more about that. Data assessment not performed. This is the whole garbage in, garbage out concept. So if the data that was purely free texted into the medication module, why isn't it participating in my drug interaction checking in my new system? Well, probably because you didn't have an NDC ID to give to your programmer, things like that. So you have to do a kind of an in-depth data assessment before you even decide if the data conversion is something you should even consider doing. Testing, of course, is a huge one. Usually testing involves the programmer getting done and saying, yep, I'm done, and I tested it, when really they should have involved the clinical staff to actually go through workflow scenarios and really look into data and really see how it prints out on documents and, oh, I found duplication, things like that. So they want to involve your testing staff as much as humanly possible. Fashionable not to do so because, well, everyone's, of course, busy, but at this day and age, they're imperative. Timing issues, if you're coming from anybody who's image heavy, I've got 6 terabytes of data that are all patient images, and I need every one of them. And it might take your conversion staff 48 hours straight to process all of the scripting behind that, or just moving the files from secure hard drive to secure hard drive can take an entire day, for example. And so maybe the concept of going down on a Friday and I've got 2 days to bring it up and have it ready Monday just gets thrown out the door. It isn't physically possible. You put a gun to somebody's head and they couldn't do it. So those are the things that need to be considered when you talk about timing issues and how to handle that. And there are others, but those are pretty big reasons why they fail. Okay, so there's always options when you go to consider doing a data conversion, and it really matters. It gets really specific on what types of data you're converting and what your systems are capable of handling and the expertise handling it. So you don't always necessarily need a conversion, so let's talk about what the options are. And this is a fashionable one right here. Let's leave our old system up and running. Yeah, because, you know, generally speaking, you've got old AR that you need to work down. So you leave the data, or you leave that system up in some form of read-only mode where you can still get in there and process through and work some of that AR down. And then maybe you don't have to do a conversion. So that's a pro. You don't have to spend the money on it. Data conversions can be expensive. However, I'm sure as you might guess here, some of the cons to that, now you're living in 2 systems. And so you're working in one and you're entering new data, but I kid you not, I just left an implementation where that had happened a few months ago where a data conversion was performed and they did a few clinical pieces, but at the end of the day, there were a lot of questions that came up with the providers on follow-up appointments needing to be scheduled, and they needed to really see their last comprehensive note and to make any kind of real decision. And they were toggling back and forth in their old system because they didn't do a document conversion. They couldn't see their old note. So they were living in both systems, and they'll probably be doing that for about a year because some of these providers at this specialty thought that they could see all their patients over the course of a year and then be able to sunset that old system efficiently. But that's a pretty big con. It's almost like it would have been worth the money had they done their testing with the clinical staff to know they would have needed that. It also depends. One of the cons of leaving that old system up is that they do require that you have a massive maintenance and maybe even additional hosting and support and all of the costs that go along with just leaving a system up. You've now doubled. You've got your old system and you've got your new system. So whatever those costs are involved, you know, if it's going to cost you $20,000 for your data conversion, you find out, and then the maintenance costs are a little less, it can be something you have to weigh out and see if you really need it. Obviously, if the old system goes down, if it for any weird reason they stop supporting it or the company goes under, there's a lot of consolidation in EMRs right now, and 100 systems are now into the top 30, and you know, the system was cloud-based, for example, and it disappears. What if you can't get it back and you should have had a conversion? That's a risk. So those are the things that most folks try to deal with when it comes to leaving an old system up and working in your new one. Another option, and this is a favorite one of a lot of people, is put it on the staff. What we're going to do is 2 weeks before we start seeing patients and we go live with our new system, we're going to have our staff get in there and hand enter all of our existing data from the old system on one screen, and we're going to put it in the new screen. And we're just going to do it manually. And that's going to be our chart abstraction electronic data conversion process. And so I tell you what, that's good news because you're using your new EMR to its full functionality. All that data is getting put in very precisely into all the necessary cross-reference SQL tables that are tough to find when you do a data conversion. You get that because you're using the system to do so. And then what? You got the data right there. It's at your hands, it's at your fingertips if you're a provider. But that is an ongoing process for a very long time. Do the staff have the bandwidth for it? So you're almost certainly talking about hiring at least one more person to help with that process every time, or your folks are just going to get worked into the ground. Which, you know, if your patient visits are few and far between, maybe you've got the bandwidth for it. I don't know too many doctor offices like that. Most of the time, these groups are back running up at 100% after a few weeks or 3 weeks, and it's they don't have a lot of time for that. So. That is tricky, and then the cons obviously are if they are entering it and they're in a hurry and they're stressed, you know, and they enter in some data and make an error, you know, I think the chances of that error increase as that pressure mounts, and then yeah, it's resource intensive, so it's cost intensive. So. That can be sort of your office developing a limp and then limping through the rest of the process. So that's not my favorite. Another option is, of course, a data conversion, a full-on discrete data conversion. So we're not talking about making a big PDF out of everybody's chart, which is the next slide. Spoiler alert. This is your full-on data conversion. So what we're talking about here is working with the vendor of the legacy system to give you that discrete data. I need meds out, you know, whatever I need, list out your clinical elements that we'd like to convert, get it in the scope, and give them to me as securely, and I will load that into my new system through scripting. And, you know, obviously that's ideal because you get to keep all that accurate, discrete data. It's reportable. You don't have to live in two systems. It's you know, the best of both worlds. It can be cheaper. You don't have to pay another resource. You don't have to keep, you know, the support licenses and the maintenance up for another software for however long you're going to do this side-by-side action. And all that legacy data is fully accessible. However, it can be expensive. So data conversion elements, and this is for years now. It's been going on to where systems are converting on top of each other. It's called stacking. And what will happen is you get bought out from one system, and they merge with another and merge with another, and all of a sudden you've got these old IDs for the last 3 demographic loads worth of patients, and that's when duplicate data starts to occur. You really have to kind of be careful about the accuracy that gets converted. So that can be kind of that expertise piece that you really need. Your coders need to be able to weed out duplicates at a high level. That's sort of that garbage in, garbage out that can be a con of the discrete data conversion. And then, yeah, cost prohibitive. So if a data conversion costs $20,000 and really, you know, it'll only be, you know, a small 1 or 2 doc group, you know, that just can't stomach that money. I mean, that's your meaningful use for year 1 right there, gone. What are we doing this for, kind of a thing. They might want to stomach that fee over the course of months just paying a salary. So discrete data conversions, that can be good, although there are some pros and cons there. And I alluded to this this other option here regarding this is pretty fashionable. There are groups out there that will do scanning, and I'm sure everyone knows a vendor that essentially you can, if you still have paper, you can box up your paper and you can send it over, and they will scan it in and send you back a big group of PDFs that represent your patient's chart. And you get PDFs that way, and those need to be converted. That is a non-discrete data conversion. That's just a loading of images into your new system. Or your legacy system can export PDFs. So they've got a utility or a feature, and this isn't necessarily CCD, although sometimes they have the ability to turn that CCD into a PDF and export it, but it's usually on a one-off case. They'll try to get you to buy a piece of their system if you want to automate that and weaponize it to export all of your patients in such a fashion. So essentially it can be expensive, but sometimes they can export all of the contents to a PDF file and give it to you. And that can be ideal too, as long as you get a master index list along with it. So you got to make sure to get, along with the images, a big list of all of the patients and the relationship to those images, because oftentimes it's not going to be John Doe birthday .pdf. You know, you're not going to know what the image is unless you have that cross-reference file. So the legacy vendor can give you that, and then you'll have both pieces you'll need to import the data. And quite often, some of the bigger vendors out there, NextGen, ClinicalWorks, Allscripts, some of those ambulatory settings will have utilities that do this already. So as long as the legacy vendor gives you that stuff, you can actually get that import utility from your vendor, and they might charge you a little bit for it, but it's not going to be anything crazy. Sometimes it's free. And load the file up and load your images into a couple of different folders, and then they'll just cycle and automatically import all that stuff into your database. And that is golden. You save on a costly discrete conversion, and you don't have two systems running. Although the bad part of that can really be a scenario where you've got a patient with a 200-page PDF file as their entire chart, and you're just kind of scrolling through it. It's not indexed, it's not categorized. That can be trouble because you're looking for a lab result and it's on the last page of a 200-page PDF. It's out of the question. Docs won't use it. So if they can give you PDFs in a meaningful way, categories or something like that, then you're golden. But if they can't, if you're handcuffed by what the legacy vendor can give you as just one big PDF for the whole patient's chart, you know, medical legally maybe it's a good reason to have it, but workflow, real life using those things is often quite a different story. So anyway, PDF conversion is an option. Okay, and my favorite option, although it's kind of pie in the sky unless you're a bigger company because it can take a couple resources to pull this off. If you're a big organization that is looking to incrementally add practices as you go, data conversion, you can live in data conversion hell for months and months and months and months with all these groups. However, if they do find themselves, and this is rare, with the ability to interface with you, and hopefully they're all on the same software and they're just multiple locations, you can spin up an interface to keep the systems in sync as you roll them onto the new practices, or onto the new software. So how this would work, and I've done this a couple times. Essentially, you set up a demographic interface, for example, and any time a patient is added or removed from one practice or the other, or added or updated, you send those AO4s and AOH to the other system so that the demographic information is the same in both places. You do want to establish a system of truth, et cetera. You can. It depends on how savvy your programming interface folks are or how savvy your software is, rather. You know, if you can configure it, sometimes software provided by vendors you don't have the source code, so you're stuck with whatever configuration options they have. But you can take those and keep that insurance data up to date in real time almost. So that's something that, you know, can be considered. Now with clinical data, that gets kind of tricky. Demographics and insurance, yeah, you can keep those up to speed. Appointments, absolutely. You can even do charge data if you wanted to, although that's usually pretty specific to one software, and you want to keep that over there and, you know, keep those that were created in the old system and do new charges in the new system. That's usually why people do that. So that's usually not interface. But clinical elements like meds, allergies, lab results, stuff like that, those are all interfaceable, but interfacing them in real time can be difficult because it takes such a large, usually there's such a large cross-reference that needs to be done before the interfaces can be turned on. A good example is allergies. There's probably 50,000 different allergen types at the Latin level, and every one of those, they don't really, like a medication can be easier because they have NDC IDs that you can match on. However, NDC IDs do actually change. Rarely, but they do change. So you actually have to do NDC ID plus a little piece of the medication name to kind of be sure about that. But essentially, the allergen IDs don't, in certain systems, wherever you get your data, First Data Bank, wherever don't really have the same allergy IDs, and so you're stuck, cross-referencing them. So there's a chance that the interface doesn't work for some types of data just because the effort is too high to get that linked up. But essentially, that's the perfect world. I mean, that's the golden goose situation here is when the interfaces are keeping data together, and it's almost like a real-time conversion all the time. So generally speaking, when you have interfaces up like that, you just don't need conversions because the interfaces themselves you can actually trigger them to feed all the data over and not just do a one-on-one. They can be queued up to send an entire load over. So things to consider. Usually I see folks doing demographics, insurance, and lab results that can be kind of kept in sync amongst them, and some clinical elements. But if there's pieces that you need that that interfaces usually don't do, you're going to have trouble in that neighborhood. So an example there would be, keeping the comprehensive note in sync. Well, the documents themselves, document interfaces do exist, and they're usually inbound from hospitals, for example. So it's very difficult because all those documents are usually stored. If they're stored in the database, they live in some format that interfaces usually aren't familiar with yet. So they'll have some DICOM or base64 data type that the image is stored in, that when exported, if you've got the Mirth engine or something loaded up as a custom interface, it can be really difficult to sort of build those those channels to decode that stuff and send it over as a PDF or a link to a PDF in real time. It's kind of, it can be a little more challenging, and it's not very often done in these conversion situations where they have tight timelines. So anyway, it kind of depends on the data, so it's something to consider. If your vendors are nice and they'll play with each other, you might get lucky and have a good experience using interfaces. All right, so generally speaking, what's my conversion process? Maybe you're going through it right now and you want to know if your folks are doing the right thing. It's not a complicated idea, but skipping one of these steps is going to shoot you right in the foot, so I'm just going to show them to you. Let's see here. So obviously, first step, discovery, and what risks are involved. It's always good to get that stuff out there first to figure out what risks you're going to run into and what the plan is for all of those, and what your timeline is. So usually the timeline's out there and someone says, yep, we're going to go live July 10th, absolutely. And then, later on you figure out that everyone's on vacation. Everybody and their brother is on vacation between July 1st and July 20th, and no work gets done. And with a conversion, you've got everybody involved, from programmers on both sides, to clinical folks, to testers. And so anyway, you got to watch the schedule on data conversions. There's a lot of pieces that need to happen, and a lot, people get sick, people go on vacation, so you really got to be careful about that. And usually that leads to discussion on these SLAs. So service level agreements, usually you got to get those in place just to kind of cover yourself in these extensive situations. Cool. And then one of the most important processes that is supposed to be done pre-sale, but sales guys sometimes don't do that, is you're supposed to do your due diligence and look at the data before you decide to purchase a data conversion, because sometimes you'll find out at the last minute that there are problems that should have been caught early on that weren't. And that usually means devoting an engineer into a sales process, which is never fun, but a sales engineer, as they are often called, get in there and look at the data and see how bad it is. See how bad it is coming from the old systems. Do they have unique identifiers? Is John Doe in one system, does he have a person number or a unique person identifier that is assigned to no one else that I can use to make sure I don't have duplicates? when I start talking about matching to the rest of the data, and all of a sudden you find out that you don't, and you're matching on last name, first name, date of birth, or last name, first name, social, and date of birth, and all of a sudden you're guaranteed to have a 10% induced duplicate patient population. And yeah, everybody's got a tool to kind of work those down, but it'll take you years, and it's just a big nightmare. And you'll hear people talking about that botched conversion for years. You don't ever want to be a part of something like that. And then I kind of alluded to this earlier, but mapping of the conversion elements and creating those teams to kind of do that is huge. And you know, what was an insurance conversion, what we have UHC, but another system has a UHC with 30 different PO boxes. And oh, by the way, they change every day. Well, who's dealing with that? Who's maintaining that during this process? And you have to identify those folks and make spreadsheets or have team foundation going and put everything somewhere. It's just, you have to kind of create that workspace, create that the governance along the project, who are going to be the contributors, who are going to be the sponsors and the stakeholders. Those things have to be done early on, or you're going to hit these walls and no one's going to know who to turn to. And I mentioned data mapping earlier, talking about allergy IDs, but essentially it's going to be the same thing for your provider names and your locations. And in the old system we use 1, 2, 3, in the new system we use something else. We have to get to do that mapping, and you'd be surprised at how many elements there truly are with even something as small as an appointment. You know, you'll have an event type, you'll have location, you have, what's your appointment type, your resource. Is it a doctor or is it a room? What's the appointment with? Is the appointment with the lab? So these things, you have to ask yourself all those questions and document everything, because if someone does have to come up in the middle of it, pick this project up, then they're going to need all the help they can get. And programmers love to not document everything. That is our #1 favorite thing to do, is do our work and not comment and not document. And if someone comes in behind you and they have no idea what happened, cannot tell you the number of times that has happened. So somebody needs to oversee that project and make sure that documentation's in there. Additional requirements. Format's huge. Tough part about this one is a lot of times you're coming from one database to another, and the vendor that you are exporting away from, you're leaving, and they don't want to work with you, or they're not happy about it. And so you're like, hey, can I get this data in a certain format? Nope. We only export it one way, sir. Here you go. Like, they're not really excited to help you. So sometimes and then the new version, they're asking you, you've got to put the data in this format. And they give you how they want you to do it, because they're the ones that have to convert this data. So they're going to put the onus on you, this middle ground. And so you need to find out if that's something you're going to do. That's back to the SLA on who's actually going to be doing that formatting. So it can be difficult, and usually you'll have to sign your life away to get a hold of one of these database specs if a vendor will actually give it to you. However, I can count, I've probably done 50 conversions, and I can count on one hand the number of times a vendor's been willing to give me a spec. And from version to version, they actually change, so they become obsolete pretty quick. But yeah, they'll make you do a field-by-field definition of everything that's going to be converted and lay the data types out, and that can be a very, very cumbersome process for someone. It's really nice to have, though, if you actually have it. If they can say, listen, it's got to be like this, I got a utility, it'll make this whole process really easy, but somebody's got to go in and give me this in a certain way. And that is a requirement. Make that a requirement. Put it in the SLA. Make them give it to you. They can. They can do it. Just make sure you get that in the contract. It'll make your life go a lot easier on the way out, and you won't forget something. I can't tell you how many times that's happened where you do the whole conversion and somebody goes, who forgot to get gender? And you kind of turn around and go, oh, yeah, we need that too. Well, if you would have had this requirement document laid out nicely and reviewed and approved by clinical staff, we wouldn't have be in this problem, in this situation. All right, so after the requirement's done, here comes the build. and I kind of already talked about mappings and that stuff, so I'm going to skip that slide. Okay, so we get down into the conversion design. So now you're actually scripting up the work, and you're converting the data, and you've determined that you've done all your mapping, and now it's on somebody to do this work. And this is where you really need to be careful on who you decide is going to do this work. You want somebody who has done this before. At no point do you want to find yourself in a situation where the person is learning on your patient data how to do a conversion, because a data type will get screwed up and you'll convert all the ones and zeros to zeros and ones. It will happen, I guarantee it. You'll be in a situation where at the last minute you'll find yourself all this data got duplicated and we can't figure out why, and it's nice to have someone who's done it before because they know the table structures, they know the layout, they know, and they've been through this whole thing, so you can rely on their expertise having done this already. You get someone in there who is cheaper, you get somebody's brother in there for $15 an hour and they can do a demographic conversion, you gotta get what you pay for. So, when you start talking about all the risks involved here that we discussed earlier, it can be a really good idea to kind of use the group that's done these before, because there'll be a lot to consider that someone learning really might not understand. And so that's kind of a piece of this is an example would be if they are bringing in discrete elements and they need encounters, for example, to tie back to each one of your elements. You can't just load up a bunch of meds and allergies and diagnosis codes and not know what date of service you had and how to get that to render into the history window of how many encounters they've had. And all of a sudden, this conversion is spinning out of control in their hands when somebody that's done this before would have that under control. So they do the build, and then it comes to testing. This is everyone's favorite thing to skip, is full volume testing. And obviously, in a perfect world, you would have multiple environments, and you'd convert the data in, and you'd be able to have a primary testing environment for all the data where you're converting every single element, and then you have another one where you convert the data and have your production simulation and your clinical staff's in there looking at it as well, and you're kind of both running and not stepping on each other's toes and reporting issues and tracking them in a software and just taking everything into consideration. That's ideal. That is absolutely ideal, but it's never followed. Here it is. I'm going to give you every testing scenario because, honestly, as a programmer, I can only test so much of your data. It's the clinical folks and the end users that got to pull up their old system because they know how to get around it, find every little nook and cranny of data that was supposed to be converted, go toggle over to the new system and find it and say, I can't find this, tell me where it is. That is truly needed by the clinical staff. Can't tell you how many times I'll lay that whole thing out. I'll put an entire testing plan in front of a client. They will open up their own mother and look down her chart and say, yep, looks good, and close it. Or they'll spot check 3 people, and that is not enough. That is just not enough. You need more than one person testing more than one scenario. Every office has about 4 workflows. Everybody knows them. You got your provider workflow, your intake staff workflow, you got referrals over there, you got schedulers over here, you got MAs that are doing this, and then you got the lab workflow, and there's always these handful of processes that get skipped every time. It's one person taking a big broad look when it should be 5 different scenarios, and they don't get done. Testing. So you got to keep a hold of that. And then usually, I mentioned tracking, so put those all into a piece of software and make sure you don't forget something, and then get sign-off. My goodness. The doctors are the ones who create the biggest amounts of screaming whenever the conversions don't go, and they should, rightfully so. Those are the ones you're going to hear from. So, as much as I hate to say it, the staff are going to be the ones affected the most, and doing the screaming, but the docs are the ones that the C-levels are going to be listening to, and the folks that are going to be, those are the people that are paying the bills. You really have to make sure that they get buy-in and that they sign off on the conversion. And you count on the number of times on one hand that I've had a provider group, signing off on something because it's time out of their day, quite honestly, which, most providers are busy as all heck, especially with these latest reform systems eating up more and more of their time. It can seem like the last thing on earth they would want to do, but gotta highly recommend that. And then what's left? Nothing else but to go live. And I alluded to this earlier. Depending on how much data and how complex it is and the time it takes, the timing issues that we talked about, how do you go live? And that's a big one. Everyone just throws the data out there, yeah, we're going to do that, but no one really talks about what it'll take. And usually that's where when you do the test conversion, you can time it. You can say, well, it looks like it took us 3.5 days to do our test conversion from start to finish. We timed it out. Okay, that's longer than a weekend. Now what? Are we dropping back to paper for a day? Are we going to, run both systems in parallel? Like, how do we do this to survive? And that's where these gap conversions or these catch-up conversions can happen, to where you can do a majority of the data gets converted over the allotment of time that you do have on a Friday night, for example. And then the practice will drop back to paper on a Monday, for example, or a Monday through a Friday, or maybe they drop back for a week or a couple days or some period of time where after that initial big bang conversion is done, that Monday or Tuesday they went to paper, those 2 days you get to do this little catch-up conversion, this little extra conversion where the office was still seeing people in the old legacy system before they turned it off, because they couldn't turn it off because the conversion wasn't done. So you do the big bang, and then you do this. It seems pointless, but you do a data pull of 2 days from the old system, and then you deliver that to the programmers, and then they basically, at a dead run, do a catch-up conversion as fast as humanly possible on a given evening. And then they take it live the next day, and they can sunset their old system. So that's one approach. If you're lucky enough to be able to do a rollout conversion with interfaces, fantastic. That reduces the manual activity, but usually it's a big bang style. I think that's what a majority of the conversions I've done are. They can be processed over a weekend. So you Friday night, close the systems down, do the export, load all the data in after you've tested it, everything, and then on Sunday you get a day, you get a buffer day to test all the stuff that you loaded in Saturday night. And then Sunday you test, and then Monday morning you go live. And then, yeah, you can leave the old system up for a day or two if you want, or until you're comfortable with taking it down, until you trust your source system, your new one. And that's it. So at the end of the day, lots of options as discussed, and I'll post these slides online. I'm going to do my level best to unmute everybody. And anybody has a question of any kind, feel free to ask now. I'm about halfway down this list because I'm unmuting everybody. Fantastic. Everyone is unmuted. Any questions whatsoever? Any weird scenarios you guys are considering with data conversions that you would like to discuss?
Hi, Dan. I got a quick question for you, if that's all right.
Yeah, absolutely.
Interested to know your experience on how often that you're using clinical CCDs produced by the prior source system and using those as just kind of out of the box and what they generally give you as what you use to seed the clinical record for the new system.
So you're not really importing that, but you're just storing it in case you need to pull it up. Is that right? So they provide you a big bunch of CCDs and they're in a folder?
No, I guess I'm
actually importing them?
Yeah, I'm actually asking them, have you done that before, or do you have any experience or heard people utilizing that as, rather than going in and pulling data out of the prior source using, you know, SQL or whatever it is.
Yeah.
Just utilizing the
absolutely.
CCD and parsing that and creating your own import process.
Yeah, exactly right. The one downside that I've done that twice now, and the downside I've had both times is obviously I wasn't able to get the note. I wasn't able to get documents and images. The CCD exportability was handcuffed by the software's ability to export only certain elements. So we were missing. So I got a lot of modular data. I got a lot of the core elements that are in the you know, MU core set, so the meds and allergies and problems and things like that. The good stuff, you know, you're able to get, but some of that other data doesn't come with those CCDs. But yeah, folks, usually you don't have the automated importability. You get some tool that allows you to, on a one-off, to import those CCDs. And so that's helpful if you need it on a one-off, but you have to script some kind of batch file that runs that executable if you want to do it in automated fashion. Probably like you were saying, if needed, I'll go ahead and pull that up and create my own process. Is that kind of what you're talking about?
Yeah, I think so. I just, as generally speaking, I just wanted to know your thoughts on using that option. I don't see a lot of people doing it either. I guess a follow-up to that is, do you get into a lot of the custom workflow within the prior source system, so having to worry about you know, where things are stored in multiple places, and you get into that in a lot of your conversion efforts with your clients?
I do. When you say multiple places, are you just within a given system?
Yeah, so for example, you know, there's an Epic, for example, or whatever other system you can use. There's a place for procedures where mammograms and, you know, any other procedures are put into the clinical chart. But then you may have a custom template, or they may be, you know, you may have practices storing it off in past surgical history, and you know, another place that they're not supposed to be doing it, and, you know, et cetera. I'm just kind of wondering what your thoughts are on that.
Yeah, absolutely. And so I've had less and less of that these days, just because a lot of the stuff has to live in certain places for meaningful use. So the system says, you know, you've got to have your encounters in these tables, or this type of data in these tables. So you're right. It's definitely, okay, I'm going to put it there, and then, yeah, it's all about where else do you want it. And I don't do it a lot just because if it's something custom, you know, I'll tie a pretty big price tag to it, just because it's usually uncharted territory. But, you know, if it's something that isn't out of the, you know, it's not anything that you haven't, a lot of those systems, you can't get yourself into too much trouble with, as far as when you start, you know, some places like Allscripts, they give you an API and you can get in as much trouble as you want to. Those are kind of, those can be interesting just if you're coming in on some really custom work. But, you know, your next gens of the world that have templates, for example, and those templates all live as SQL tables, so you can load those up really easy and do custom multiple places. You're right, that happens all the time.
Yeah. Okay, thanks.
Yeah, thank you. Anybody else have any questions? All right, I'll post these slides. If you have any questions, you want to email me directly, you see the email address on the screen there. I appreciate everybody coming out, and hope you have a good rest of your week. Thanks, everybody. Bye.